All right, let's jump right in. Today, we're heading into the cath lab. We're going to break down one of the most important procedures in all of cardiology, and we're going to focus on the super high-yield stuff you absolutely need to know for your exams and your rotations.
Okay, this quote from Harrison's really nails it. Even with all the incredible advances we've seen in non-invasive imaging, this procedure is still the gold standard. It's where we get the final definitive answers about the heart's plumbing and its pressures.
And the history here is just incredible. It all started with a crazy self-experiment by Werner Forssmann back in 1929. Yeah, he did it on himself. And then the whole field of seeing the arteries was blown wide open by an accidental discovery. It's an amazing story of how this went from a wild idea to the cornerstone of modern cardiology.
So here's our game plan. We're going to walk through this step by step. We'll start with the basics, then get into why you'd order one and how it's done. And then we'll get to the really good stuff, interpreting the data to make those life-or-death clinical decisions. Okay, first things first. Let's get our terms straight. Because you'll hear cardiac catheterization and coronary angiography thrown around a lot. They're definitely related, but they are not the same thing. Think of it like this. Cardiac catheterization is the whole mission. It's the act of getting that tiny tube, the catheter, up to the heart. Once we're there, we can do a bunch of things, like measure pressures. Now, coronary angiography is a key part of that mission. It's the imaging, where we inject dye and take X-ray movies. It gives us that beautiful, detailed roadmap of the arteries. So a cath can be purely diagnostic, just to get intel, or we can go a step further and actually fix something we find, which is called an intervention. So that brings us to the big question for you as a clinician. When do you actually pull the trigger and send your patient for this test? Let's break down the most important reasons.
Okay, if you're studying for boards, this slide is absolutely critical. The most urgent lights and sirens reason is a STEMI, a big heart attack. The goal there is to get to the cath lab immediately and open that artery. For other acute situations like an NSTEMI, the cath is essential to figure out what's going on and what to do next. And for our stable patients, we're sending them if their symptoms are really bad despite meds, or if a stress test shows us that a big chunk of their heart muscle might be in trouble.
But it is not just about blockages, not by a long shot. The cath is crucial for things like valvular disease. We can directly measure the pressure drop across a tight aortic valve to see just how bad it is. If someone comes in with new heart failure, we need to know if it's because of blocked arteries. And for those really tricky diagnoses like constrictive pericarditis, a cath is pretty much the only way to get the definitive answer.
All right, so your patient is on the schedule. They're heading into the lab. What actually goes on in there? How do we get all this vital information? The very first decision is a big one. Where do we go in? For years, the ephemeral artery in the groin was the standard. But now there's been a massive shift toward using the radial artery in the wrist. And why is that? It's really all about safety. There's a much lower risk of bleeding, and patients can get up and walk around much sooner. The one catch is we have to make sure the hand has good backup circulation, and that's exactly what the Allen's test checks for.
The procedure itself is like a carefully choreographed dance. Get this, the patient is actually awake, just lightly sedated. After numbing the area, we place a small plastic tube called a sheath into the artery. Then, watching on a live X-ray screen, the cardiologist carefully guides the catheter up to the heart. If we go through a vein, that's a right heart cath to check pressures on the right side. What we're focusing on today is the left heart cath, going through an artery to check pressures on the left side and to do that all-important angiography.
And this right here, this is the money shot. This visual shows the catheter tip parked right at the opening, the ostium, of a coronary artery. From this perfect spot, we inject a little puff of contrast dye and boom, the whole vessel just lights up on the X-ray, letting us see its entire structure in real time. Okay, this is where the cath really flexes its muscles, in a way no other test can. It's not just about the pictures, it's about the physics. How do we take these direct pressure readings and use them to diagnose some really complex heart problems?
All right, get your highlighters out because this is a classic boards question, differentiating these three conditions. With tamponade, fluid is squeezing the heart, so all the diastolic pressures become equal. In constriction, it's a stiff sac around the heart, so the left and right ventricular diastolic pressures equalize, and you get this classic square root sign and a prominent Y descent. But with restriction, it's a stiff muscle, so the left-sided pressures are going to be way higher than the right. Understanding these patterns is key.
And we don't just stop at those pressure patterns. We use that raw data to calculate some really powerful performance stats. We can figure out the cardiac output, how much blood the heart is actually pumping, using a couple of different methods. From there, we can calculate how much resistance the blood vessels are putting up. And for tight valves, we can use a special formula to calculate the exact valve opening area. It's incredibly powerful stuff.
All right, we've crunched the numbers on the pressures. Now for what many people think of as the main event, the pictures. How do we look at this luminogram, this map of dye in the arteries, and figure out what's going on? You've got to have a system. First, you just define the basic anatomy. Then, you hunt for narrowings or stenoses and estimate how bad they are. After that, we often do a left ventriculogram. That's a bigger puff of dye right into the main pumping chamber, to watch how the walls are squeezing. We're looking for areas that are weak or hypokinetic, which tells us there might be some old damage there.
So what happens when the angiogram is kind of iffy? You see a blockage that looks maybe borderline? To get a closer look, we can use IVUS. It's literally a tiny ultrasound camera on the tip of the catheter that lets us see a 360-degree view from inside the artery. It's fantastic for seeing how much plaque is really there and for making sure a stent is placed perfectly.
But here's an even more important question. Just because a blockage is there, is it actually causing a problem? Is it limiting blood flow? That's the question FFR answers. We use a special pressure wire to measure the pressure drop across the blockage. This tells us the true physiological impact of that narrowing, which is often more important than just how it looks.
And here it is, the number you have to burn into your memory, 0.80. An FFR value less than 0.80 is the high-yield cutoff. It's the red flag. It tells us that, yes, this specific blockage is causing ischemia, it's starving the heart muscle of blood, and that means fixing it with a stent or with surgery is probably going to help the patient.
Finally, we have all this incredible data. The pictures, the pressures, the FFR. Now what? We have to weigh all that information against the potential risks and figure out the absolute best path forward for our patient. Now, this is a very safe procedure overall, and serious complications are thankfully rare. But it's not zero risk. The things we see most often are related to the access site, like bleeding or a bruise. We also have to be really mindful of the kidneys, because the contrast dye can be tough on them, especially in patients who already have kidney problems or diabetes. Okay, the procedure's over, the report is written, the images have been reviewed, the pressure's analyzed. Now comes the most important part of all. How do we put all these pieces together and make a decision that could save our patient's life?
And this is really the whole point. The Cath report isn't just a result, it's a roadmap. For mild disease, the path is optimizing medications. For 1 or 2 significant blockages in the right spots, that path might lead to putting in a stent, or PCI, right then and there. And for really complex disease, like a blockage in the critical left main artery or multiple blocked vessels, the data clearly points us toward bypass surgery. This is the true power of the Cath. It provides the definitive clarity we need to choose the right path and completely change our patient's future.